Hello guys, welcome to ACE Anesthesia. Today's video, the topic of discussion is neuromuscular blockers and relaxants. So this is the second video which comes under drugs in anesthesia series. So as we all know, neuromuscular blockers and relaxants are used in our everyday anesthesia practice. So it forms an important part of balanced anesthesia, which includes like giving good analgesia and akinesia as well as amnesia to the patient. So because of its rampant use, it's very important to know about the various type of neuromuscular blockers which are available and also the reversal agent. So neuromuscular blockers are the drugs which will help in producing akinesia, that is the patient will be immobile during the portion of the surgery. So neuromuscular blockers can be broadly classified into depolarizing neuromuscular blockers and non-depolarizing neuromuscular blockers. Okay, we'll be discussing briefly about each of the drugs which comes under these two major groups. So among the depolarizing blockers, we will start with two important drugs, that is the Succinylcholine, okay, and the older one which was available was called as decamethonium. So Succinylcholine, so in this video we'll be seeing first about Succinylcholine. So Succinylcholine is also called as Sugamadex, okay. So this is one of the depolarizing muscle relaxant. So Sugamadex or Succinylcholine is a quaternary ammonium compound. Okay, so this is available in the vial as 1 ml equals 50 milligram as a clear colorless solution. So it is basically available as a 5 ml vials or 10 ml vials of Succinylcholine is available. Okay, so Succinylcholine, the action of a mechanism of action for a depolarizing muscle relaxant is that they will be binding to the nicotinic acetylcholine receptor. Okay, so Succinylcholine basically contains of two acetylcholine molecules which are joined by the acetate bond. So it is very similar to that of acetylcholine in its structure. They will be binding to the nicotinic acetylcholine receptor and they will cause initial depolarization. So they will cause depolarization at the neuromuscular junction. So this depolarization caused by this Succinylcholine is called as the phase 1 block. So they will first cause depolarization, that is a sustained contraction. But what happens that acetylcholine is basically degenerated at the neuromuscular junction by the acetylcholine esterase. So this I have explained in the neuromuscular physiology video. You can look for that video and see in detail regarding the neuromuscular transmission and its physiology. So as we all know that acetylcholine, which is a normal neurotransmitter that is present, it is degenerated at the neuromuscular junction by acetylcholine esterase to acetate plus choline. Okay, but what we have here is the Succinylcholine. Succinylcholine is degenerated by the plasma choline esterase. Okay, plasma choline esterase, also called as butyl choline esterase, right? So this is an enzyme that is not available in the neuromuscular junction. Where is it present? It's present in the plasma. So what is there? Basically Succinylcholine has to diffuse from the neuromuscular junction and it has to go into the plasma where it is degraded by the plasma choline esterase or the butyl choline esterase, and then it will be forming into succinyl monocholine plus choline, right? So succinyl monocholine plus choline. So these are the two compounds which are formed from the degradation of the succinylcholine from the plasma, right? So next we will be seeing about what is the So this is like the pharmacokinetics. So succinylcholine in the presence of plasma cholinesterase, which is present in the plasma, they will be dividing into and they will be degraded into succinyl monocolin plus colin. Okay, so what happens that the action of the succinylcholine is that first it causes a transient depolarization, followed with a sustained because it causes depolarization, it is coming under the category of a depolarizing muscle relaxant, followed by it will cause paralysis of the muscles because of the consistent joining at the or blocking at the nicotinic acetylcholine receptors. So, after finishing this, we will see a little bit about the enzyme, that is the plasma cholinesterase. Okay, so plasma cholinesterase, this is an enzyme that is synthesized by the liver. So it is basically synthesized in the liver and it is present in the plasma. Okay, so plasma cholinesterase function is to degenerate the succinylcholine into succinyl monocolin and colin. Okay, so this plasma cholinesterase, normally it is decreased in conditions like advanced age, okay, or patients with advanced liver diseases, or patients with pregnancy, okay, or in patients who are taking drugs like monoamine oxidase inhibitors, oral contraceptive pills, etc. So these are the group of patients which will have decreased levels of plasma cholinesterase or the pseudocholinesterase. So one thing which we have to remember regarding this plasma cholinesterase, where so there is what is called as the dibucane number. So this is very important in consideration with succinylcholine. I'll tell you why. So this is what is dibucane number. So dibucane is basically a local anesthetic, right? So dibucane number is the percentage of pseudocholinesterase, okay, or butyrylcholinesterase that is degraded by dibucane. Okay, so dibucane, what it does, this will degrade a normal butyrylcholinesterase or a plasma cholinesterase or pseudocholinesterase. These are interchangeable terms. So normal plasma cholinesterase, dibucane will be more, it will basically degrade more than 70% of a normal plasma cholinesterase. But if the patient is having like a atypical pseudocholinesterase or plasma cholinesterase, dibucane number will be less than 30%, right? So this is the importance where it will tell us about the genetic composition or the genetic modification of the plasma cholinesterase. Another number which we have is called as the fluoride number. Okay, so fluoride number, also normal variant fluoride will inhibit more than 60%. Abnormal, it will be less than 40%. So these are dibucane number and fluoride number. Both of them will tell us about the genetic composition or the variation of the plasma cholinesterase. So this forms of great importance in case of phase 2 blockade, which we see in case of succinylcholine. I'll explain about phase 2 block in the further few minutes, right? So we studied about succinylcholine. It's a quaternary ammonium compound, how it's available in the vial. We saw about its mechanism of action, and we saw little bit about the degradation of succinylcholine and also importance of dibucane number, fluoride number, right? So with regards to succinylcholine, the onset of action of succinylcholine. So succinylcholine, the onset of action is within 1 minute. So normally the duration of action, it will be lasting from about like 7 to 10 minutes. Okay. Sometimes even up to we can say 12 to 13 minutes. So this will be the duration of action of succinylcholine. Then one more thing is that regarding to the succinylcholine, what are the main uses of it? So first it is used in process of intubation. The normal intubating dose of succinylcholine is 1 milligram per kg body weight. It is of great importance in conditions with rapid sequence induction, okay, where it's done in patients with full stomach or patients considered to be full stomach. We do rapid sequence induction. We may require slightly higher dose, 1 to 1.5 milligram per kg body weight of succinylcholine. Another use of succinylcholine is in conditions with laryngospasm. Okay, in laryngospasm, the dose that is required is about 0.1 milligram per kg body weight. Right? So this tells us about the duration as well as the dosage of succinylcholine. Next, we will see what are the effects of succinylcholine on the various systems. So succinylcholine, as I said, important side effect of it is the cardiovascular system, right? Because of its muscarinic effect also, it causes bradyarrhythmias. So it is often given along with glycopyrrolate or with atropine. Okay, why does it cause and in which patients it is very common is especially in pediatric age group. Okay, because they have more of vagal dominance, they will be more prone for bradyarrhythmias, and also in patients who we are giving the repeat doses of succinylcholine, what happens is that there is accumulation of the metabolite, that is succinylmonocholine, which will be acting on the SA node, right? So that will be causing bradycardia in case of repeated doses of succinylcholine. Okay. Next comes another complication of succinylcholine, which is hyperkalemia, that is increased in potassium levels. So this forms importance in patients with chronic kidney disease who are often associated with raised potassium levels. So it is believed that a single dose of succinylcholine, okay, one dose of succinylcholine will increase the potassium by 0.5 to 1 milli equivalents. Okay, so how do we treat the hyperkalemia? Treatment of hyperkalemia, it includes like mechanical hyperventilation, or we can give calcium gluconate at the dose of 15 milligram per kg body weight, or we can give nebulization, that is salbutamol nebulizations, or we can flush out the excess, that is we can create mechanical hyperventilation, or we can also flush out the excess potassium from the body in the form of giving diuretics like furosemide. Or another method of doing this is by causing the potassium to move into the cell, that is we give dextrose with insulin, where we put 10 units of insulin in 50 ml of 50% dextrose or 100 ml of 25% dextrose, right? So this will cause the movement of potassium into the cells. So these are the ways we will treat hyperkalemia. Next, another complication of that is the succinylcholine is increase in intraocular pressure. So what is a normal intraocular pressure? It will range from 10 to 15 millimeter mercury. So single dose of succinylcholine will increase the pressure from 5 to 6 mm mercury. This is of great importance in patients with perforated eye injuries. But it is not like a complete contraindication. It's a relative contraindication to use succinylcholine. In case a child comes with like a perforated eye injury, and we don't have drugs like rocuronium and with a full stomach, we don't have drugs like rocuronium, what do? We can use succinylcholine because it's a relative contraindication. Why? Because for induction in a rapid sequence induction, we will be first using drugs induction agents like either thiopentol or propofol, both of which will cause fall in the intraocular pressure, which is balanced by the succinylcholine, which may cause slight increase in the intraocular pressure, right? And often studies say that like patients with perforated eye injuries often would have like cried or strained themselves, which inherently prior itself causes raise in the intraocular pressure, right? Another thing or the side effect of this is it increases the intracranial pressure. Similarly, we don't use it as like a relative contraindications in patients with raised ICP, but that also prior to inducing we will use usually the induction agents that causes the fall in the intracranial pressure. Okay. Another important complication which we have to talk is about two terminologies, that is Scholen apnea and the phase 2 block. Okay. So what is Scholen apnea? Scholen apnea is basically apnea which is occurring for more than 20 minutes after a single dose of more than 20 minutes. Okay. After a single dose of succinylcholine at a dose of 1 to 1.5 milligram per kg body weight. It is called as Scholen apnea. Okay. So that will cause more than 20 minutes, which is called as Scholen apnea. Now, what is phase 2 blockade? Phase 2 blockade is mainly seen when we use like very high doses of succinylcholine, that is high dose more than 3 milligram per kg body weight, or we use like infusions of succinylcholine. These were used in before days, that is earlier days when we didn't have the modern muscle relaxants. They used to use very high dose of succinylcholine to carry out a case, or they used to use infusion, which was often associated with delay in the recovery from the neuromuscular relaxant action. Okay, so or the patient had need to be mechanically ventilated because the property of the succinylcholine used to be very similar to a non-depolarizing muscle relaxant. Okay, so this is called as the phase 2 block. Okay, so in phase 2 block, the cause of the phase 2 block is mainly because of atypical pseudocholine esterase. So these patients will have inability to degrade the succinylcholine, and hence there is prolonged action of the paralytic effect of succinylcholine, right? So the causes of the phase 2 block may be because of atypical pseudocholine esterase, and this may be either qualitative or quantitative. Qualitative is mainly atypical varieties, and quantitative if it is given with additional drugs like magnesium sulfate or lignocaine, etc. That is the qualitative causes of phase 2 block. So in phase 2 block, what we see is the phenomenon of fade. Okay, phenomenon of fade that's usually seen with the non-depolarizing muscle relaxant. There's also post-tetanic potentiation. Okay, post-tetanic potentiation. This is seen in the, when we do a neuromuscular monitoring, we'll observe that there is phenomenon of fade, there is post-tetanic potentiation, there is delayed recovery and need for mechanical ventilation. Okay, sometimes it has been noted that because it's very close to the activity of a non-depolarizing muscle relaxant, it gets sometimes antagonized by an acetylcholine esterase inhibitor like neostigmine, but not always. Okay, the phenomenon of fade, all this is seen. Why? Because it's, as we saw, the phase 2 block occurs with a very high dose of succinylcholine. So it's believed that at such a high doses, succinylcholine also blocks the presynaptic acetylcholine receptors, which are responsible for the release of acetylcholine, that is release of acetylcholine from synaptic vesicles from a reserve pool to an immediate release pool. So this also one of the causes, and the delayed recovery is because of conformational change in the nicotinic acetylcholine receptor because of the prolonged dose causing desensitization, right? So these are two important terminologies which we must remember regarding succinylcholine, that is succinylcholine apnea and the phase 2 blocking, right? Apart from this, another side effect of succinylcholine, which it's a separate topic in itself, but here I must mention it, that is malignant hyperthermia. Okay, malignant hyperthermia. So it's also one of the drugs which is often associated with patients having malignant hyperthermia. So we saw about the basic important points about the succinylcholine. So before moving on to the non-depolarizing muscle relaxant, we must know certain important terminologies like what is ED95. Any drug we take, we will tell us what is ED95 with respect to muscle relaxant is that the amount of dose which is required to prevent the movement of the patient, that is 95% patient, to a supramaximal stimulus is called as ED95. Usually intubating dose, okay, intubating dose of any drug will be 2 times ED95, okay. Now, 3 terminologies which we have to remember. First is what is priming. So, priming is basically when we are using a non-depolarizing muscle relaxant, when we give like a 10% of the total intubating dose prior to the about 3 to 5 minutes prior to that of a total intubating dose of a non-depolarizing muscle relaxant, this will hasten the action of the non-depolarizing muscle relaxant by about 30 to 60 seconds, and this procedure is called as priming. Okay. Next we come to precurization. Precurization is when we are using succinylcholine. Okay. When we are using succinylcholine, okay, if we give 10% of a non-depolarizing muscle relaxant dose, okay, about 3 to 5 minutes prior to giving succinylcholine intubating dose, right, this will hasten the action of succinylcholine and also will help in reducing the myalgia that's often affiliated to the usage of succinylcholine because of the muscle contraction. So this is called as the precurization, also called as defasciculation, defasciculating dose of suck, right? When we next we come to self-taming, that is giving a small dosage of succinylcholine, that is about 1/10 or 10% prior to giving the entire intubating dose of succinylcholine is called as the self-taming, right? So these are the important things before we have to know prior to moving on to a non-depolarizing muscle relaxant. So next coming to the non-depolarizing muscle relaxants. Non-depolarizing muscle relaxants are those which will be binding to the nicotinic acetylcholine receptor, and they will prevent the binding of acetylcholine to its receptor and hence prevents the neuromuscular transmission. They are also believed to bind to the presynaptic acetylcholine receptors and hence it prevents also the release of acetylcholine from the synaptic vesicles. So non-depolarizing muscle relaxants, they can be briefly classified into 2 types, which is the steroidal type and benzyl isoquinoline compounds. Okay, so the steroidal group of non-depolarizing muscle relaxant as well as benzyl isoquinoline, both of them can be divided into long-acting, intermediate-acting and short-acting non-depolarizing muscle relaxant based on their duration of action, right? So when we come to steroidal group, the longer-acting one is the pancuronium, okay, where the duration of action may last up to like 2 to 3 hours, whereas an intermediate acting which includes vecuronium, rocuronium, and rocuronium, are the short acting, are the intermediate acting ones, right? When we come to benzyl isoquinoline, the long acting is D-tubocurare, whereas intermediate acting ones includes atracurium and cis-atracurium, right? And then short acting, it includes mevacurium. There's one special one which is the ultra short acting, right, which is not available in India and not FDA approved in many countries, but we can just know the name, that is gantacurium. Okay, so let's see brief features about each of the non-depolarizing muscle relaxants. We'll start with pancuronium. When we describe it, always we'll start with it's a non-depolarizing muscle relaxant. It belongs to the steroidal group of non-depolarizing muscle relaxant. It's a long-acting one. And pancuronium is available, usually pancuronium is available in the form of 2 milligram per ml as a 2 ml vial. Okay, it's a clear colorless solution. It's available. And pancuronium usually is associated, it's a long acting one, as I said. It's associated with often increase in the heart rate and vagolytic effect, as well as sympathomimetic effect, causing increase in the blood pressure. And dosage of the pancuronium, it is given at the, for the intubating dose, it will be 0.08 to 0.12 milligram per kg body weight, right? So this is the dose of the pancuronium which we use. Next we will come to vecuronium and rocuronium. Coming to vecuronium that is present, it's also a intermediate acting steroidal group of non-depolarizing muscle relaxant. Vecuronium, if you would have used, it's available in the form of lyophilized powder. Okay, so it has to be reconstituted. Lyophilized powder, which is usually 10 milligram per vial. Okay, it basically contains substances like citric acid, mannitol and sodium hydroxide to neutralize the buffer, right? So vecuronium is given at a dose of 0.2 milligram per kg body weight. Okay. Next we will come to rocuronium. Rocuronium, which is very commonly used nowadays, and it has gained importance because of a reversal agent, especially Sugamadex. Okay, so rocuronium is also an intermediate acting steroidal group of non-depolarizing muscle relaxant. Right, rocuronium is available in the form of 10 milligram per ml in the form of like a 5 ml vial. Okay, so rocuronium, the thing is about rocuronium, it is available as also a clear colorless solution, right? And rocuronium is also metabolized along with the vecuronium, both of them in the liver, and they are excreted by the kidneys. So benzyl isoquinoline, we have the older one which used to be used in those days, which is the D-tubocurare. D-tubocurare, which was basically used as a arrow poison. Okay, it was used as arrow poison, right? And it is arrow poison. D-tubocurare is a long-acting benzyl isoquinoline compound, right? And it's often associated with problems like it is a very, one of the major side effect of it is that it was a ganglion blocker. So it will cause intense hypotension to the patient, right? So this was one of the important things which was which has to be remembered, and it was discovered by Griffith and colleagues, right? So next we will come to our commonly used atracurium and cis-atracurium. So atracurium and cis-atracurium, both of them have a special feature. They are not dependent on the liver for its metabolism and kidneys for their excretion, right? So atracurium is available in the form of 10 milligram per ml, okay, as a vial or as an ampule. So 10 milligram per ml, it's available as a clear colorless solution. Right, atracurium, basically the classic feature of it is that it is metabolized by Hoffman's degradation, which is basically temperature and pH dependent plasma degradation, and another method is by remaining about 30% is by ester hydrolysis. But one important concern is there is a metabolite to atracurium. If we use it for longer duration of action, it produces what is called as laudanum, which is a CNS stimulant. So this is important only in patients like in liver disorders where the metabolism of this laudanum it accumulates and it will act as a CNS stimulant. Okay, so atracurium intubating dose will be 0.5 milligram per kg body weight, right? So 0.5 milligram per kg body weight will be the intubating dose of atracurium. Next we come to cis atracurium. Cis atracurium is a newer drug, right? So this is also available in the form of 2 milligram per ml, okay, in the form of a clear colorless solution, right? So cis atracurium intubating dose will be 0.2 milligram per kg body weight. One thing to be remembered, because here also cis atracurium gets metabolized by the Hoffman's degradation. So since it is a temperature and pH dependent, both atracurium and cis atracurium, they have to be refrigerated and kept at 2 to 8 degrees Celsius in a cold chain, right? So one thing about atracurium which when comparing both of them is that atracurium causes histamine release, which is often associated with hypotension, bradycardia, bronchospasm, etc. So it's a relative contraindicated to be used in asthmatic patients, whereas in case of cis atracurium, it is not so. So there is no histamine release in cis atracurium, and there is also no ester hydrolysis in cis atracurium. Then little bit to know about gantacurium, though it's not available in India. It is an ultra short acting benzoisoquinoline compound of non-depolarizing muscle relaxant, and gantacurium will usually have some cysteine byproduct, and it also has ester hydrolysis for the degradation. The dose of gantacurium is about 0.2 milligram per kg body weight. It's often sometimes seen associated with transient hypotension and tachycardia. So next we'll be seeing little bit about the reversal agents. So these reversal agents are used to reverse the action of the neuromuscular blockade caused by the non-depolarizing muscle relaxant. Important thing to remember is that these non-depolarizing muscle relaxants will still activity may persist post the reversal. Hence it's very important to know about the residual paralysis and also have to know about the ability of the patient to take the breaths prior to extubation. So whenever we come to extubation, we know that there are certain clinical criteria like ability to head lift for 5 seconds, or ability to lift the legs for 5 seconds, or ability that is there is a tongue depressor test which we may perform patient's ability to open the eyes, good power tone, and like able to generate a good tidal volume like more than 300 regular breaths and negative inspiratory pressure of about -25. So these are the clinical criteria, and essentially it is basically the the TOF monitoring or the neuromuscular monitoring that's also forming a very important part of reversal, right? So all this apart will come to reversal agents. We have the conventional reversal agents like our acetylcholine esterase inhibitors. So these are basically acetylcholine esterase inhibitors. We have neostigmine, right? We have pyridostigmine, and we have edrophonium. Okay. So these are the agents that are present as conventional acetylcholine esterase inhibitors. And we know the unconventional one, that is the Sugamadex. So acetylcholine, out of which I think all of us use neostigmine majorly. I have personally not used pyridostigmine or edrophonium for the reversing. Why? Because first is edrophonium is a very short acting drug, right? When we reverse it with a longer usage of a neuromuscular blocker, then the effect of this edrophonium will persist for a very short period of time. So therefore, it's not very effective against the reversal for a neuromuscular blocking agent, right? And pyridostigmine is a very long acting one. So neostigmine that is present is an appropriate one which will use daily life which is basically an acetylcholine esterase inhibitor. Basically, they will be increasing the amount or availability of the acetylcholine at the muscarinic and that is at the neuromuscular junction. So inherently, when you increase the acetylcholine, you increase the neuromuscular transmission. So neostigmine, we know that it's often used in our everyday practice along with glycopyrrolate. Why? Because first is neostigmine, it also blocks the muscarinic receptors. Therefore, it's very important that we do not have any side effect of it like the bradycardia. So onset of neostigmine. So neostigmine, when we see the vial is available in the form of 0.5 milligram per ml. Okay. So it will be available in this dosage in our everyday vials if you notice. Nowadays we get a combination of neostigmine with glycopyrrolate together in a same vial itself. Okay. We use neostigmine, but the conventional ones we used to get as 0.5 milligram per ml. Okay, it's a clear colorless solution, and neostigmine is given at a dose of 0.05 milligram per kg body weight. Right? The onset of action of neostigmine will take about 3 to 5 minutes. Okay, it takes about 3 to 5 minutes. And the duration of action of neostigmine will persist up to 90 minutes. Okay, right? So these are the basic features which we have to know about neostigmine. We have also seen that how it acts. It's basically an acetylcholine esterase inhibitor. Coming to the action of neostigmine in central nervous system, they will be causing blurred vision. They cause pericorneal injection, and in case of and in a state of confusion in cardiovascular system, they will cause bradycardia. So we have to give them with atropine or with glycopyrrolate, right? Third is they will cause increased salivation, right? And they'll also cause bronchospasm or increased bronchial secretions. Okay. They'll also cause nausea, vomiting, increased abdominal motility, right? So these are the features which we normally see with the neostigmine. So neostigmine metabolized 50% by the liver and 50% it gets excreted through the kidneys, right? So we saw about the neostigmine, the dosage, and we saw about the effects of neostigmine. Another thing we have to remember that the onset of neostigmine takes about like 3 to 5 minutes. So once you give the reversal, it doesn't mean we take out the tube immediately because the action of neostigmine takes a certain time. Another thing is that the reversal is to be given to the patient for a non-depolarizing. If you are using a neuromuscular monitor, the TOF should be more than 0.4. Okay. You cannot give if the TOF is like less than 0.4, it cannot be reversed, right? Whereas it should be given only if the TOF is more than 0.4. So whenever we are using this neostigmine, we have to keep these things in mind. Next we come to edrophonium. Edrophonium is not used, but a point about it is that it's used in what we call as the tensilon test to differentiate between myasthenic crisis and cholinergic crisis. Please do read about both of these. So coming to the last portion of this video, we'll be talking about the unconventional one which is rampantly used nowadays, that is the Sugamadex. Sugamadex was discovered in Oregon laboratories in UK by Attenborough. He was like a pharmaceutical scientist, right? So Sugamadex is a cyclodextrin. Okay, so this was basically having a lipophilic center. So the molecule had a lipophilic center and a hydrophilic periphery. Right, it was a hydrophilic periphery. So this was basically very useful against steroidal group of drugs, that is especially the vecuronium, rocuronium. Okay, very commonly used to antagonize the effects of, that is, they will basically encapsulate these steroidal group of this non-depolarizing muscle relaxant. So Sugamadex, how does it act? As I said, it encapsulates this non-steroidal, that is steroidal group of non-depolarizing muscle relaxant. Whenever we use the Sugamadex, so they will basically cause the like a diffusion gradient. So when you give it in the plasma, they will cause the rocuronium and they will to move out of the neuromuscular junction and they will encapsulate the rocuronium, right? So that's how the Sugamadex works. So it's basically, it's available in 100 milligram per ml as a 2 ml vial and also available as a 5 ml vial. Okay, so it's a clear colorless solution, and Sugamadex is very useful in conditions for, especially when we have used rocuronium, that is in difficult airway situations where we were unable to ventilate or unable to intubate. So we can immediately reverse this effect of the non-depolarizing muscle relaxant. Right, it's also very useful where we have used rocuronium for rapid sequence induction and we have encountered a difficult airway situation which previously was where we used to use Scolin and it had its own complications. So some very few reports of anaphylaxis or allergic reactions are seen with Sugamadex, and also it's kind of it's seen that it accumulates in patients with chronic kidney disease. Right, so Sugamadex is the dosage at which we give. Sugamadex also depends upon the stage of the neuromuscular blockade which we are in, right? So if the patient is in like intense block, that is, we have given like a neuromuscular blocking agent and then we want to reverse the effect immediately, where when we see the post-tetanic count will be 0 basically. So this is intense block. So in this situation, Sugamadex is given at a dose of 16 milligram per kg body weight, right? So when we are in like a deep block where post-tetanic count is like 1 or 2, so in this situation, the dose is about 4 milligram per kg body weight. But when we are in rest of all situations where our TOF may show ratio, either it is like TOF count of 1 to 4 or TOF ratio ranging from till up to 0.9, we can use at a normal dose of 2 milligram per kg body weight. So TOF count this is, okay. So ideally they say that if the TOF is 1, you need not even reverse it. But often in our daily situations, we prefer to at least use dosage of 2 milligram per kg body weight, right? So these are the few points which we have to remember regarding Sugamadex. So we have to remember that one molecule of Sugamadex will encapsulate one molecule of a steroidal group of non-depolarizing muscle relaxant. This is very commonly used against rocuronium, sometimes against vecuronium. Not very useful against pancuronium because pancuronium is very large molecule compared to the Sugamadex, right? So the encapsulation is not very effective. So apart from all this, we have to know that the neuromuscular blockers, these are used in ICU also, sometimes in conditions where we have to intubate the patients or we have to hyperventilate the patients having increased work of breathing, or we have to have selective hypercapnia, we have conditions where we have to reduce the intracranial pressures in patients with status epilepticus. But using in ICU has its own demerits of using a neuromuscular blocking agent. Therefore, we often ventilate the patients in ICU with good analgesics instead of muscle relaxants, because they may be associated with complications like patient being immobile, increased risk of pulmonary embolism, deep vein thrombosis, sacral pressure source. They may also have problems like ICU awareness. So these and all can be avoided if we avoid using the any muscle relaxant in ICU. So we have come to the end of this video where we have discussed about the neuromuscular blockers and the relaxants. We have seen about the depolarizing muscle relaxant, that is succinylcholine, and non-depolarizing muscle relaxant, and brief details about each of them. We have also seen about the relaxant, that is the neostigmine, and also Sugamadex. I hope this video was useful to all of you. Keep supporting. Thank you.